Okay, C3, C4, C5 keeps the diaphragm alive. Neck movement, shoulder movement, upper limb movement. Okay, that is a cervical nerve root, cervical spine function. Okay, the thoracic nerves, just think about what's located in the thoracic cage. So part of that will be rib movement, breathing, vertebral column movement, postural muscles from your back. Okay, also your vital organs, heart, lungs, liver, gallbladder, pancreas. Okay, and then lumbars, reproductive, lower limbs, pelvic, okay, and sacrum, lower limbs. All right, these have the nerve roots that come out. All right, we have this thing called a plexus. Okay, and we have a cervical plexus. All right, then we have the brachial plexus. All right, and then the lumbar plexus and the sacral plexus. Okay. All right, this one is our dermatome map. Okay. I have a video on this later for you all to see. The dermatome map is actually a very important neurological map. Okay, one reason would be to understand if a person has a skin eruption of blisters, for example, shingles. Okay, shingles tend to follow dermatome patterns. All right, so classically, shingles will follow, let's say right here around the rib cage. Okay, so C6, C7, or excuse me, T6, T7, T8. All right, these are named after the nerve roots. Okay, so your dermatome map is a very important neurological map to help you understand what's going on with your patient better. Okay, and they are named after the nerve root that innervates that area. So the C4, it's because that is innervated by C4 nerve root. So if there's an issue in this area, you know where at in the spine to look, right? C4 nerve root, so C4 bone in the spine. Okay, if a person has, so if you look at their pinky right here, their pinky finger and their ring finger, if they come in and that area is numb or tingly, well, you're like, oh, that could be the C8 nerve root in your spine. There may be an issue there, and that's why you're having numbness and tingling in your pinky and ring finger, which is digit 5 and 4. Okay. Let's say a person has a very strange feeling here, like over the fibula bone that goes into like the big toe, top of the foot, right? That is L5. So they come in complaining of, some sort of pins and needles or numbness and tingling or whatever in that specific area, and they'll trace it. Now the patient doesn't know that they are tracing the L5 dermatome pattern. They're just showing you exactly where their symptoms are. Okay. And they usually say it this way, man, it's the weirdest thing. Like this part of my leg, and they'll trace it right here. They're like, that part of my leg down to my big toe is like numb and tingly. Like it's weird. And the other side is not like that. And in your own mind, you're going, oh, I know, it's L5. There might be something going on at your L5 nerve root. Okay. So back to shingles. If the dorsal ganglion, okay, which is, let's see, a picture of it should be right here. All right, so we'll get back to that in a minute, that particular slide, but that's what we're looking at is the ganglion. If that level of your spine, so let's say it's T6, okay, that ganglion is affected, okay, something happened to it, you're going to break out in shingles. So you get these rashes that will follow that T6 dermatome pattern. Okay, now if it's bilateral, you'll get it on both sides. It could be unilateral, which means just one side. All right, now the shingles is a resurfacing of herpes zoster type 1. Okay, in lay terms, that's the chicken pox. All right, so if anybody has had the chicken pox, let's say you got it when you were a kid, so let's just say at age 8, you got the chicken pox. That means is you got the herpes zoster virus and you're symptomatic for, let's just say, a couple weeks, right? You get the blisters, it itches, all that kind of thing, and it's the chicken pox. All right, fine. So you're 8 years old, you're symptomatic, it sucks for a couple weeks, and then your immune system learns how to fight it, and then eventually it fights it, and eventually your immune system wins and suppresses the virus, but it suppresses it in the dorsal nerve root ganglion. Okay, so the different ganglions in your body. And that's all over your body. That's where your immune system decides to suppress it. So what happens is, so you're age 8, you get it. After a couple of weeks, you're over it and you're fine. Your immune system wins. Forever, that virus will remain dormant in all the different ganglion in your body unless you become immune compromised. Okay, as soon as you become immune compromised, what that means is you're lowering your immune system, you're suppressing it, and likely the reasons why are the usual suspects of immune suppression: stress, lack of sleep, poor nutrition over a period of time equals suppressed immune system. So now the opportunistic organism, in this case, herpes zoster or the old chicken pox, resurfaces. Now keep in mind, you're no longer 8 years old. You're now a full-blown adult. You could be 20, 35, 55, whatever. You're an adult. And you went through a season where it was pretty stressful. So your immune system became compromised. And the area of nerve root irritation, the one that's irritated the most, and a lot of people have mid-thoracic pain because of posture, the way they slouch. And so biomechanically, that's very hard on your mid-spine. So therefore, if T5, T6, T7 vertebra are pissed, then the nerve root is pissed, and therefore the ganglion is pissed, and that will be the area of greatest immune compromise. So that's the area the shingles will surface. It's very dermatome specific. Could be unilateral, which means one side, or bilateral, which means both sides. So you get the blisters that surface in that area. It could happen in, C2 could be the one that's hurt, so you break out in the neck. It could follow the L2 pattern, so that part of the thigh, or L3. Okay, so any of all these dermatome patterns that you're seeing, any of those areas can be affected. It usually goes after the weakest one. And by definition, the weakest nerve root is the area of greatest biomechanical stress, which means it basically like pinches the nerve root, which means that area is not functioning very well. So that's the area that surfaces. Okay. So your best bet to resist disease, resist your chicken pox from resurfacing in the form of shingles, okay, to resist all that kind of stuff, is to keep your spine healthy, okay, to keep all of this as healthy as you can. Okay, so we call that spinal hygiene. Okay, spinal hygiene. And that's just a fun way of saying keeping your nervous system healthy. Keep your brain and your spinal cord as healthy as you can. All right. And some of the ways you do that is adequate sleep, good nutrition, stress management. Okay. Try to keep that very low. Um, Immune boosting techniques, which means you stay away from, best you can, stay away from pro-inflammatory things. Okay. Try to keep inflammation low in your body. Basics of diet and exercise. Okay. So things in that family, right? Because that's what keeps your immune system strong. And then it also, the exercise part, stretching and all those things can help keep your spine healthy. Okay. So the healthier you keep your spine and your central nervous system, then the healthier it will keep you. All right. So that's another reason for knowing dermatome patterns, as you can tell in a person. If a dermatome area gets pissed, it will show. And because you know your map, you know what nerve root is affected. Okay. So we're going to build on this as we go through all this, all these different slides. We'll build on it we'll see how a lot of this works with your dermatome patterns. You could also say nerve root map. Okay. So the nerve root map and the dermatome map are basically the same thing, because the areas you see like S3, L2, T1, that is the nerve root. That's the area of the spine that comes out and innervates that part of your body. Okay. Now, it's going to get a little confusing later because these nerve roots have another name. Okay. They have a peripheral nerve name. All right. So it does get a little tricky a little bit later, but we'll get into that. All right. Any questions so far? Okay. Okay, this one, now the stuff we're going to get into with the cross section of the spinal cord. Okay, this does get tricky. All right, now you'll notice I gave you several slides. Actually, what I would probably do is make several copies of this. Okay, make at least 2 copies. Okay, because we're going to start writing on this thing, and it's going to get really busy. So to not make it look so busy, I'm going to end up drawing on this twice. Okay. That's up to you. But for now, I would certainly make 2 copies of this. Because I'm going to draw on it and then erase it and then draw on it again. All right, so first of all, you're looking at a cross section of the spinal cord. Okay, so we took a spinal cord and cut it, and then now we're looking down on top of the cord. All right, so let's start by just naming parts. Okay, so the butterfly shaped looking thing, that's the gray matter. Okay, so all this that you see there, that's considered the gray matter of the spinal cord. And this runs up and down the entire length of the cord and even diffuses into the brain. Okay, and everything else is the white matter. Okay, it's white matter because it's myelinated, and the myelin has it's a fatty type substance, so it has that whitish appearance. So that would be the white matter. Okay, the gray matter is gray because of the cell bodies, all the different cells that you find within the gray matter. All right, the other thing to do is to divide the cord in half. Okay, we have a right side and a left side. All right, so you're looking, this is the anterior part of the cord. So this is the front of the person. And here's the posterior aspect of the cord. So that makes this the left side, and that makes that the right side. Okay, so orienting yourself on a cross section of the spinal cord is very important. Okay, so it's important to divide the spinal cord in half because we are a right side and left side person. Your right brain controls the left body, and the left brain controls the right side of your body. And that is called when things have to cross over. So the left brain crosses over to the right body. That's called decussation. All right, we'll talk more about that in a little bit. So that's why it's important to divide the cord in half, because you have a right side and a left side. Okay, some other anatomy parts of this. First of all, you have the ascending tracts. So they're going up. Okay, so ascending, right? The ascending tracts. You can also say afferent, which is also sensory, right? So that's body to brain. All right, so we have different tracks or highway systems that go from your spinal cord to your brain. So they travel up. Afferent, which means it's sensory. Okay, so they're going from body to brain. Okay, then you'll notice on the chart here you have descending tracks. Okay, so the arrows are pointing down. Okay, so the descending tracks are efferent, okay, motor, brain to body. Okay, on this particular diagram, they only showed you the arrows on one side. All right. They just happen to be showing it on the right side, but this is actually going on both sides. So let me get rid of some of this. Okay, so you'll notice the arrows are going up here, but not on this side, even though that's what's going on simultaneously as well. All right, the darker circles on this thing, on this cross section of the spinal cord, I was trying to show you motor. Okay, so the darker circles are motor. The lighter colored circles, okay, that is sensory. Okay, now remember, afferent and sensory are synonymous. Also, your ascending. So all these are the same thing. Ascending, afferent, sensory, they're all synonymous with each other. Okay, so even though on this particular diagram, they're just showing things on the right side, this is also occurring on the left side as well. So both the left and the right side of the spinal cord are constantly experiencing ascending and descending pathways. Okay, now we're going to start naming some other parts. So let me get rid of some of this. All right. Okay, since this is the posterior aspect of the cord and this is the anterior aspect of the cord, that will help you. Just knowing location is going to help you with naming things. Okay. So another name for posterior is dorsal. Another name for anterior is ventral. Okay, these are synonymous with each other. Depending on the anatomy book, okay, or the author, or your reading, they may use posterior or dorsal, anterior or ventral. All right. So these here, all of these specific parts there, that's the dorsal column. Okay, so collectively, all of those are the dorsal column. Okay, so try to hang in there with me because this does get tricky. All right, so all of those are the dorsal columns. All right, now we're going to break them down into their individual names. Okay, this is going to be, now this is the abbreviation. We'll get into the full term in a second. The FG. Okay, so the location of these closest to the midline, those are the FGs. Fasciculus, gracilis. Okay, so I call them, during the lecture stuff, I refer to them as FG, but that is the fasciculus gracilis. That's the name of that particular tract. And it is a sensory tract, which means afferent, which means body to brain. And the FG happens to function sensory about the belly button down. Okay. So what that means is if you look at a person, let me derotate that. Okay. When you look at a person from the front, all right, about where their belly button is, okay, about where the belly button is, all of this sensory information that goes in, all of the sensory information that goes into the body and into the FG part of the spinal cord, the fasciculus gracilis. Okay, and by the way, this is tactile information. So the fasciculus gracilis is responsible for tactile information coming into the body from everything about the belly button down. Okay, tactile means non-pain, non-temperature feeling. Okay, so your body is sensitive to pressure, it's sensitive to touch. Okay, it's sensitive to certain things certain sensory things that are non-pain, non-temperature. That information from the belly button down will go into your spinal cord and it goes up that particular tract, the fasciculus gracilis. Okay, and we're going to be mapping this out in a little bit as well. All right, just laying some groundwork here. All right, the column next to it, the vesiculus gracilis is right here. It's still part of the dorsal columns. It's more lateral to the midline, so it's the more lateral column, and that is the FC. Okay, that's the abbreviation for it, and that stands for the fasciculus cuneatus. All right, so the FC stands for fasciculus cuneatus. All right, so this one, the fasciculus cuneatus, is also, it's a tract, sensory. Okay, it's a sensory tract, which means it's letting you know it's going from body to brain, so it's ascending or afferent, and it's responsible for sensory input about the belly button and up. Okay, about the belly button and up. So going back to this guy, all of this is going to be your fasciculus cuneatus, the FC. So as information is going into your spinal cord about the belly button up, it's going to go in and specifically travel on the fasciculus cuneatus. Okay, and it's also tactile information, which means non-pain, non-temperature. So when non-pain, non-temperature sensory input goes into your body about the belly button up, it's going to travel up the fasciculus cuneatus. And we have a right and left side because, you know, we have a right and left side body. So information that's coming in, let's say from your right hand, is going to travel in. It's going to, so right hand up your arm, into your shoulder, into your spine, specifically at the fasciculus cuneatus at the level of the cord. Okay, and that goes back to your dermatome map. At the level of the cord, well, look at this. Okay, so let's say it was this hand that experienced the tactile information. Okay, so the right hand. Well, look at your dermatome map, C8, C7, T1. Okay, so those areas And actually C6 is involved. So basically C6 through T1, which means all that sensory information, non-pain, non-temperature, tactile, is going to go in through those nerve roots and into that level of the cord, right? So into that level of the cord. So it's area appropriate. So if your right hand is experiencing this tactile information, it's not going in at T8. That's not level appropriate. So that's what I mean by at the level of the cord. So you have to visualize the spinal cord, which is all this, and what level is this information going in? It's level appropriate. So if your foot is experiencing something, C7 is not level appropriate. Okay, level appropriate would be your dermatome map here. So that's the area it's going in through the foot into the spinal cord. Okay, so that's what I mean by level appropriate. And you're going to hear me say that quite a bit. Okay, if a person came in with numbness and tingling in their shin, I'm not thinking T2. That's not level appropriate. I'm thinking somewhere in the low back, like L4, for example, because that is the dermatome map. Another way of saying that is your neurological map or your nerve root map. And so I'm thinking, wow, there might be something going on in their low back, why they're feeling an issue in their lower leg, because that's level appropriate. All right. Okay, so now let's draw out, we're going to go to this blank one here. Now we're going to start doing a map. Okay, so you'll want to divide it. Oh, wait, we got to do some more anatomy here. Okay. So we said that the butterfly-shaped looking thing is the gray matter. Okay, I'm going to highlight this so it stands out better. All right, so we have some more anatomy parts to identify. Okay, we said that all this was the gray matter, okay, that I highlighted in green, but there are specific parts to it. Okay, since this is the posterior aspect of the cord, that makes this the dorsal horn. Okay, specifically on the left. So that's the left dorsal horn. Okay, so let me go back down to this one since this is less busy. Okay, so if that's the left dorsal horn, and that makes this one the right dorsal horn. Okay, posterior aspect of the cord, anterior aspect of the cord. So that makes this one the ventral horn. on the left. And that makes this one the right ventral horn. Okay. All right. So now this area has a name. Okay, that happens to be on the posterior aspect of the cord. So that makes this the dorsal root. Okay, so the dorsal root on the right, all right, because that is on the posterior aspect. And over here, that's also the dorsal root on the left. Okay, so here's that ganglion right there that I was talking about earlier. So that's the dorsal root ganglion. Okay, and you find it on both sides, the dorsal root ganglion, and that is a sensory ganglion. Okay, so that makes the dorsal root a sensory root. And when you hear the word sensory, you already know that's afferent or body to brain. Okay. If if this is the dorsal root and this is the anterior aspect of the cord, then that makes this the ventral root. Okay, on both sides here, ventral root. Okay, and you'll notice that the ventral root works itself, or the ventral horn and the ventral root are connected. The ventral horn and the ventral root are connected. The dorsal root and the dorsal horn are connected. Okay, so I'm going to go down here where it's less busy, but it's not moving. Okay. right, my apologies. It's just not responding. There we go. Okay. All right, so all of this in red, and I'm doing red on purpose, because in the book and all the anatomy stuff, the motor, they denote in red. And sensory, they'll denote in blue. Okay, so everything that I highlighted is going to represent motor. Okay, so to recap, this area is the ventral horn, and this area is the ventral root. Okay, so ventral horn, ventral root. And that's located on the anterior or ventral aspect of the cord. Okay, so that means you can divide the cord into quadrants. Okay, do your crosshairs. Okay, this one divides it into right and left. And this one divides it into posterior and anterior. Okay, so back here, this is the sensory area. All right, so that's the dorsal horn. And that makes this the dorsal root. Okay, and that specific knot, that's the dorsal nerve root ganglion. Okay, and those run up and down each level of the cord. All right, I know that's a lot. Okay. So any questions on just naming the anatomy parts for now? All right. So let's take a break. All right, we'll take a 15. Actually, let's come back at 9:45. So that's a little more than 15 minutes. All right, and then we'll pick up. We're gonna dive in deeper to this cross section of the spinal cord. It gets fancier. Okay, so try to hang in there. Bear with me. All right, so see you around 9:45. Okay, we have some more anatomy parts to do. So let's divide the cord in half. Okay, and we'll point out some more spots here. All right, so we already did the fasciculus gracilis. Okay. Hold on a second. and fasciculus cuneatus. All right, now we're going to look at this ascending tract. Okay, now it is on both sides. So everything that we're doing on the cord here is always bilateral, but just so it's not so busy, we're just going to name the one side. Okay, so in other words, we're just going to look at this one for right now, even though it is found on both sides. Okay, this one is divided into 3 different ascending tracks. Okay, and thus the 3 different arrows there. So there's a track, there's a track, and there's a track. Okay, this one is the lateral spinothalamic tract. All right, this word right here, spinothalamic, is letting you know just from the word alone that it is ascending or afferent because it says spine to thalamus. Okay, the thalamus is in the brain, so this is letting you know it's afferent, spine to brain, thus spinothalamic. Okay, and it is responsible for pain and temperature. So your lateral spinothalamic tract, which is located right there. So on this side, it would be located right there. Spinothalamic tract. It is an ascending tract responsible for pain and temperature interpretation. Okay, the next one right here, that is the spinotectal tract. Okay, and this is responsible for touch related to visual reflexes. Spinotectal tract okay, related to visual reflexes. So our vision is responsible for a lot of things. Okay, it helps with balance. Obviously, it helps you see. There's depth perception. There is a visual interpretation of things. Is it friendly? Is it threatening? Okay, if I came up to you with a basketball and pretended like I was going to throw it at your face, you would have some sort of a visual reflex. Okay, so vision plays a very important role in a lot of things that our body can do. Okay, so that's the spinotectal tract. Then we have this area, which is the spinothalamic, or the anterior spinothalamic tract. And this is for crude touch and pressure. Crude touch and pressure. Okay, so there's fine touch, like the way a pen feels in your hand. And then there's crude touch, which is getting to more into um, is this harmful? Okay, like for example, you could pick up a thumbtack, and if you're careful, that would be light touch, or excuse me, fine touch. But if you squeeze it, you kind of already know through the spinal tectal tract that this is going to hurt, because the sharp part of the tack can go into your, pierce the skin and cause pain. So you would recruit this area, the anterior spinothalamic tract, be an example of that. Okay, and now the crude means it's not extremely specific. It's just a general sensation area, because when your body is trying to protect itself, to some degree, it doesn't matter if it's a very, very specific area. All your body knows is this is harmful, therefore pull away. Okay, so that's the crude part of it. All right, so I'm gonna go. Okay, I'm gonna erase all of this, and then we're gonna look at this area and that area. So we have two more um, ascending pathways to do. All right. Okay, so we're gonna look at this one and this one. Okay, the arrows are showing you it is an up arrow, so ascending or sensory or afferent. Okay, remember this is the posterior side, this is the anterior side of the cord. So this is the posterior spinocerebellar tract. Okay, I don't know why it's doing that. So let me try that again. Okay. All right, the posterior spinocerebellar, so it's letting you know it's going from spine to cerebellum. And the function of the cerebellum is balance and proprioception stuff. So the function here is unconscious balance. Unconscious balance is so when you get up from your chair and just walk around, in a way, you're not really thinking about it. You just do it. Okay. It's almost second nature. Well, it is second nature. Okay. You don't really think about certain modes of balance. You just do it. You just get up, walk around, you coordinate yourself to sit down in a chair. You could coordinate yourself to sit down on the floor. Let's say, like, in a cross leg position. You could coordinate yourself to walk to your car, open the door, and sit in the driver's seat. Okay. These do require balance and motor skills, but you don't really think about it. You just do it. Okay. Now, if you take something more specific, like try to put you on a tightrope, that's your balance is going to be different if you're not used to that. All right, so then you just went from unconscious balance to a more conscious balance. Different areas in your body are trying to be recruited to walk on a tightrope, and because you're not used to that level of balance, your body's going to behave different. So in other words, we basically spend a lifetime developing our balance centers, and to the degree of how you challenge your body is to the degree of your own balance. Okay, easy example. Let's just say a person has never ridden a bike in their life, ice skated, rollerbladed, okay, skis, skateboard, stand up paddleboarding, anything like that. And that's basically their life. All they do is sit, walk around the house, walk to the mailbox, and that's kind of it. Like literally their whole life. No playgrounds, no nothing. As you can imagine by that example, their balance is not going to be that well tuned because they didn't really challenge themselves to create better balance. So their level of unconscious balance will be very limited. Then you take a person who challenges their balance centers by, let's just say, doing the bike riding, the skiing, the snowboarding, the ice skating, um, you know, playgrounds and balance beams and anything else, you can really think of that just challenges your balance centers. Now they will have developed a better sense of balance. And the more they do it, it just turns into unconscious balance. You don't really think about it like a bike ride. Been riding a bike for 15 years, you don't even think about it. You just get on the bike and you go because you have developed that posterior spinocerebellar tract very well, and the communication from body to brain is very well, and the balance and coordination that comes with it, you just do it. Okay. And then this part, you can kind of look at it as the cousin. That's the anterior spinocerebellar tract. And it's also unconscious balance. Anterior spinocerebellar tract. Okay, located on the anterior anterior lateral part of the cross section of the spinal cord. Okay, the difference, or the reason why you have two, is the anterior does a lot of lower body balance function. All right. Okay, let's go to some mapping. Okay. All right, so we're going to divide the cord in half. And what I'm going to start doing is showing you pathways from the body to the brain and how we map this out. Okay, so I'm doing this in green because I'm going to do the sensory in blue. And then later we'll do the motor in red.
Are you still screen sharing?
I don't know. I can't see what you're looking at.
I
No.
can't see your screen either.
Oh, so it's not screen sharing.
No.
Okay, okay. All right, how about that?
Yeah, you're good now.
Okay, cool. So what I did is just drew this that green line there, just to divide the cord in half, because we're going to show you the pathways. Okay, give me 1 second. Okay. All right, so the other thing I want to, draw in here is the brain. Okay, this is a frontal, like, cross section of the brain so that you have a right side of the brain and a left side. Suppose I could make that bigger. Okay, also, we're going to put in here the brain stem. The brain stem and the thalamus. All right, so you have the cortex of the brain, the thalamus, and the brain stem. All right, and this one is going to be a tactile pathway. All right, and we'll start on the right side. Okay, and then let's just say it's the hand. All right, now a while back we looked at this thing called the homunculus. Okay, the homunculus was the area in the brain at the primary sensory cortex. Okay, these terms should hopefully ring a bell. You had the central sulcus, and behind the central sulcus, here, let me kind of draw that out here for you. So if this was the brain, right, there was that central sulcus there, and then behind it was the postcentral gyrus, and in front of it was the precentral gyrus. Okay, and the precentral gyrus is the motor, and the post-central gyrus is sensory. So the way the body works is you have sensory that comes in, your brain processes the information, and then you have a motor response. And then they drew a map over the homunculus area. Remember the foot and the leg and the knee, the hand, the face, all that was, so in a frontal view of the brain, okay, they did something like the foot, picture the foot was there, and the leg, your body trunk, okay, like your neck, hand, shoulder, and your face. Okay, so this was the map. Okay, and what that means is as information is going into the brain, if it's your foot that is being activated, then that's the area of the synapse in the brain because that's the homunculus. If it's your hand, then its synapse is right there. Okay, so we're going to try to mimic that through these drawings here, or the mappings. Okay, it's not going to be 1,000% accurate, but you'll get the idea. Meaning the homunculus, because this is a very small picture. All right, so let me get to my markers here. Okay, so this is the hand. And because it is tactile, okay, remember we have the fasciculus gracilis and the fasciculus cuneatus. All right, I'm going to erase those because it's too busy. All right, because it's the hand, okay, remember the fasciculus cuneatus is tactile information from about the belly button up. So you're touching something, the sensory information goes in the dorsal nerve root into the dorsal horn. Because it's belly button up, it's fasciculus cuneatus. Synapses on that particular track goes up to the brain stem, and this is where it crosses over to the other side. So that's called decussation. That happens in the pyramids. Okay, happens in the pyramids in the brainstem. It has to go through the thalamus and then to that part of the cortex that operates the hand. Okay, I'll trace it one more time in green. So your right hand is touching something that's tactile, okay, which means non-pain, non-temperature. Information goes in the dorsal nerve root. Okay, remember that's the sensory ganglion, so it's a sensation, helps you with the sensation. Goes into the dorsal horn, which is part of the gray matter. Because it's belly button up, because it's your hand, that would be the fasciculus cuneatus tract. Goes up. This is all ipsilateral, by the way. Everything so far for tactile is on the right side until we get to the brainstem. That's where it crosses over. Now we're on the left, decussation. Has to go through the thalamus to the appropriate level of the cortex. Now, the appropriate level of the cortex means it could be the foot part, it could be the knee part, your trunk part, your arm, and so on. Okay, the sensory cortex in the brain has very specific locations to sense the different parts of your body. Okay, now let's do the same thing, but on the left side. Okay, it's really the same thing, but just on the left side. All right, so let me get rid of this. All right, divide your spinal cord in half. Here's your brain, cross section. There's the thalamus. There's the brainstem. Right side of the person, left side of the person. All right, this is the left hand, tactile. All right, so we have the FG and FC. Because it's tactile at the hand, which means belly button up, it's going to go into the FC. So sensory information goes in. So through the hand, up the arm, into the dorsal nerve root, into the dorsal horn. It's going to hit the fasciculus cuneatus, go up ipsilateral to the brainstem, cross over in the brainstem, specifically the pyramids in the brainstem. All incoming information has to go through the thalamus, and because it's the hand, it goes to about that area in the primary sensory cortex. Okay, let's do a foot. So you can see fasciculus gracilis. I draw the cord in half. Left side, right side of the person. Okay, here's our brain, brain stem, thalamus. Okay, so the right foot, tactile. Okay, information, here's your FG and your FC. Because this is belly button down, we're going to be focusing on the fasciculus gracilis. So information comes in the dorsal nerve root, that's the sensory ganglion, goes into the dorsal horn. Remember, all sensory input goes through the posterior aspect of the cord. So dorsal nerve root, now we're in the dorsal horn. Okay, now there's a lot of synapses that take place. We're not really getting into all that right now, but it does synapse and work its way over to the fasciculus gracilis because this is belly button down, goes up ipsilateral in the pyramids of the brainstem, crosses over, goes through the thalamus, and because it is foot, okay, the foot is like that area in the cortex. Okay, now I'm going to do the left side on this picture here. I'll do it like in a different shade. Okay, so this is the left foot. Tactile information comes in. The the dorsal nerve root, okay, goes into the dorsal horn. Because it's the foot, it goes over to the fasciculus gracilis, goes up to the brainstem, specifically the pyramids, decussates, crosses over, goes to the thalamus, and then the thalamus sends it to the appropriate area of the primary sensory cortex. So left body goes to the right brain. Right body goes to the left brain. All right. Okay, so now we have to map out or do some anatomy stuff for pain and temperature. All right. So back to this one. Okay, we had that spinothalamic tract. All right. This is going to be our pain and temperature track. So let's map that out. All right. So let's divide the cord in half. And we'll have this area. Okay, which means we're going to be focusing on the left side for now. So we'll just say the left hand. And remember, there was 3 tracks within that lateral system. Okay, and one of them was the spinothalamic tract. Okay, so I drew this on the right side on purpose because pain and temperature crosses over at the level of the spine. Keep in mind, everything has to get to the opposite brain. So if it's your left hand, it has to get to the right brain. Tactile goes in ipsilateral, but pain and temperature crosses over at the level of the cord. All right, so here's the hand, pain, or pain and temperature. Okay, so information goes in the dorsal nerve root into the dorsal horn. Now watch this. Crosses over at the level of the cord. Okay, now we are contralateral. We went from ipsi to contralateral. So now we are on the other side of the cord. Okay, let's draw our brain, thalamus, brainstem. Okay, so now the information is going to go up the cord. We're already on the other side, so we've already decussated. All right, it's still going to go to the brainstem, still going to go to the thalamus, but because it's the hand, it's going to go to about that area of the sensory cortex, but pain, because of the tract that it followed. Okay, and then your pain substances in your body are released. These are nociceptive, which means pain, fibers. So they behave a little bit different than your balance or tactile fibers. Okay, so same thing, different color. So your hand gets hurt, information goes in. Now keep in mind, this is at the level of the cord. All right, so that's where you have to go back to your dermatome map, that anatomical man that looked like a mummy with, you know, all the lines all over him. And you look at the hand, well, we looked at it earlier, right? C6, C7, C8, T1, nerve root stuff out of your spine goes down to your hand. So that's the level of the cord that we're looking at here. Okay. The information, the pain information is not going to go into your hand and through L5. That's not the appropriate level of the cord. Okay. So pain and temperature comes in, and I'm just redrawing this with a different color. Well, never mind. That just got rid of it. Okay, crosses over to that spinothalamic tract, goes up, and then to the appropriate level of the brainstem. Okay, let's do the other side. All right, give me a second to get that back. Okay. All right, so here is our brain. Thalamus, brainstem. Okay, this will be the right hand, pain and temperature. All right, there's that anterolateral system, 3 different tracks, specifically the spinothalamic tract. Okay. So your hand gets hurt, the information goes up through the hand, through the arm, into the spinal cord, specifically the dorsal nerve root at the appropriate level of the cord, into the dorsal horn. All sensory information goes in to the dorsal parts of spinal cord. Because it's pain and temperature, it crosses over at the level of the cord, hits the spinothalamic tract. We are now contralateral, goes up to the brainstem, to the thalamus, and to the appropriate part of the homunculus, the primary sensory cortex. About that area is the hand. And you've now just interpreted the pain that happened at your right hand. Okay. Any questions on any of this? All right, so now let's do some motor. All right, so we're going to go back to this guy because it's got the motor tracks visible here. And the motor are the darker colors here. Okay. All right, since motor is usually denoted in red, we'll go ahead and mark it in red. All right, so this guy, which is on the left side, and here's the right side, and this guy, they're the same thing, just on the other half of the spinal cord. Okay, so this guy and this guy are the same. These and these are the same. All right, these guys and these guys are the same. Just for simplicity reasons, we'll just look at one side of the cord even though it's the same on both sides. All right. So let's start with this one. Okay, that is the lateral corticospinal tract. Okay, now the word cortico cortex is letting you know this is motor because it's brain to spinal cord. Okay, so the cortico spinal. All right, so cortex to spine, corticospinal. This is letting you know it is descending motor efferent. Okay, they're all the same thing. Descending pathways, motor pathways, efferent pathways. All right, the function of the corticospinal is voluntary movements. Okay. Voluntary movements. Excuse me. Okay, the next one here, that is the rubrospinal tract. Okay, rubro is a part in the brain to spine, so this is letting you know it's descending motor efferent. This helps with coordination of body movement. Okay, and posture. Okay, rubrospinal, coordination of body movement and posture. So when you also go to the opposite side here, you're going to see that okay, down here, let me get rid of some of this stuff. It's getting busy. Okay, look at this guy there. That is reticulospinal. All right, and its function is posture. Okay, I'm going to change the color. Just to do less erasing. All right, so this one here. So that's a tract. That's a descending tract. That is the vestibulospinal. Okay, this also has to do with posture. All right. Okay, so this one is tectospinal. Okay, brain to spinal cord. And this helps with head and neck movements. So, but vision is involved. Okay, so head and neck. Movements with vision. Okay, so in other words, vision is involved to help the tectospinal tract do its thing, okay, with head and neck movements. Okay, and one more. Oh dear. All right, let me see if I can close this out. Start over. It's not erasing. Oh goodness. All right, so we have one more to do, and that's this one. Okay, that is the anterior corticospinal tract, and that is also responsible for voluntary movements. All right. So to map this out, all right, this is the corticospinal. Okay, we'll draw our okay. So that's a terrible brain. All right, so let's say it's the hand. So it's right there. All right, so information will come in. Whoops, I gotta get on the other side. So information will come down. Remember, this is descending. Okay, go through the thalamus, go through the brainstem. Okay, cross over, go down the spinal cord to hit that particular corticospinal tract, go through the ventral horn, through the ventral nerve root, so that you can do your motor thing, okay, which is movement. All right, so, of course, the movement is going to vary based on, like, the way you pick up a pencil is different than the way you pick up a 20-pound weight is different than the way you grip a basketball, right? So you just do all these calculations to do the motor skill, right? So writing calligraphy is a little bit different motor skill than cutting up carrots or shooting a basketball, right? But it's still a motor response. So that's what I mean by your motor thing. Just depends on what you're doing. Okay. All right. Let's do another one. One more. Goodness. Sorry about that. All right, right side, left side, we'll do a, so let's draw our brain. All right, here's the, we'll just call that one the corticospinal tract. Or did we just do that? We just did corticospinal. Let's do, so there's rubrospinal. Okay, rubrospinal. Okay, but it's on the left side, which means we're over here. So there's your thalamus, brainstem. All right, and let's say it's the foot, so we'll be there. Information, the motor information comes down. Okay, crosses over, hits the, whoops. All right. Hits the rubrospinal, which sends information to the anterior horn, to the ventral horn, so you can have your motor foot. Okay. Now, what we're drawing out is a very simplified version of how these pathways take. It is absolutely crazy how much they have mapped out. Okay, that would be for more like advanced neuroanatomy stuff. We're not going to take it to that level because there are many, many, many pathways in the brain. So here's our brain. So once it goes from that homunculus part, it'll synapse to a certain part, and then another synapse, and then another synapse. Multiple synapses as you're working your way down to the spinal cord, and multiple synapses within the cord itself. So it is a lot more complicated than just homunculus to thalamus to brainstem to cord to the gray matter to the body part. Okay, so we mapped out a very, very simple version of all this. All right. So it's pretty incredible how our nervous system does so many things so quickly. with all the different synapses and all the different coordinations and our pain, our temperature, our sensory stuff, our tactile, everything. The brain is constantly being bombarded with sensory input. Okay, vision, hearing, taste, smell, the way your skin is feeling things. On top of you're constantly trying to stay balanced and coordinated so you don't fall out of your chair, so you don't fall when you stand up, and on it goes. Okay, plus your thinking process, the motor skills it takes with writing. So there's a lot of sensory motor there. You hear it, you see it, you're interpreting it, and you're writing it, you're drawing it, you're trying to process it. Just tons of information that the brain is able to do. Okay, so we have some more parts to go through. All right, so we got a lot more slides to do. So let's take another break, okay? And when we come back, we're gonna pick up with the next slide. Spinal cord, and there's some of your nerves. We're gonna look at some parts of the brain, okay? Get into the association fiber stuff, sympathetic, parasympathetic, okay? Then the cervical and brachial plexus and the peripheral nerve names. We'll get into some testing, so neurological testing, muscle testing, reflexes, and so on, okay? All right, so let's come back at like 11:05. Okay, we'll get started around 11:05. Okay. All right, so this slide right here is showing you the mid-thoracic area, but it also, in a way, shows you how the spinal cord, the nerve root, and the spinal nerve itself behave. All right, so right, you've got the cord that runs up and down your body. It's going to give rise to a nerve root, okay, that eventually turns into a nerve. And then those nerves wrap around, and then they have branches and branches and so on, and innervate everything in your body. Now, in this particular case, it's just showing you what it would look like in the thoracic spine. Okay. All right, on the brain, so this is a superior view of the brain. In a way, it's just a reminder of some of the parts we looked at. Okay, so occipital lobe. All right, this one is showing you the pre central gyrus. The central sulcus and the post central gyrus. Okay, I did that in blue because that's your sensory. And then the precentral is motor. All right, you can also see the motor here and the sensory there. All right, frontal lobe, parietal lobe area, and temporal lobe. Okay, this is the entire right hemisphere, cerebral hemisphere. There's your entire left cerebral hemisphere. Okay, so cerebellum. So that's for balance and proprioception. Okay, all of that is the brain stem. Temporal lobe, occipital lobe, parietal lobe, frontal lobe. All right, this one is the medullary tracts. Okay, so I'm going to highlight some colors or change some colors here. Okay, so these fibers all right, those are projection fibers. Okay, so the yellow that you're seeing there are projection fibers. And they connect the cerebrum to other parts of the brain and spinal cord. All right, they connect the cerebrum to the spinal cord. Okay, as you can see there, here's like the cerebrum area, and there's your spinal cord area. So they are wires that connect cerebrum to the spinal cord. Okay. In males, the area, there's a higher concentration or a higher number of wires, okay, quote and unquote wires or nerve fibers. Okay, are these wires here that travel left and right there? All right, those are the commissural fibers. Okay, commissural fibers. All right, so that's part of the corpus callosum. Okay, and this is hemisphere to hemisphere communication, hemisphere to hemisphere communication. And these are, in females, Okay, they have a higher number of these wires. Okay, so men have more wire connections from spinal cord to brain, and women have more wires connection from hemisphere to hemisphere. Okay, some brain scans, functional MRI of the brain, and stuff like that have shown that over and over again. This is why, so the higher number of wires in females in the corpus callosum is what gives, kind of stereotypically gives women the ability to multitask. And the higher projection fibers in males gives them the ability to be more compartmentalized, right? To focus on one thing at a time. And so in relationships, this can be frustrating, right? So sometimes the woman is like, why can't you just, kind of go down the list of talk on the phone, make the schedule, prepare the lunches, do the laundry, clean everything up while having a conversation about the next 6 weeks at the same time. Okay, that's multitasking. And, guys kind of want to be in their kind of one zone at a time. And that can be frustrating. But I think that if people can understand the neurology behind what's going on, you can extend more grace and freedom to each other to be, in a way, to be who you are, right? So the men can get frustrated and they're like, well, why can't she just focus on one thing? And this is usually in relationships, right? Like marriages, for example, have been around. I mean, you're living in the same home and you're around each other. And I mean, if you really want to know somebody, like you live with them, right? You really get to see all their nuances and habits and whatever, like the whole 9 yards. And so this is where this stuff comes out is the different, now listen, this is just neurological behavior differences. Then you throw in there, their own personality and, what makes that person, right? That's just, that's how all this works. And then we throw in hormones, right? That also shapes differences in, men and women and just some differences through hormones. So just as an easy example here, um, the corpus callosum, which is hemisphere to hemisphere, can allow for more multitasking ability, and the projection fibers allow for more focused and compartmentalized um, abilities. Now, obviously, there's exceptions to the rule, right? Some men are multitasking and some women are not, and some women are very compartmentalized, so focus on one thing at a time. Okay. And same with the hormones. In general, testosterone is a male characteristic thing, and estrogen, progesterone, oxytocin is a female characteristic thing. And therefore, um, there's some, emotional, behavioral, love making, uh, and all that kind of stuff differences because of hormones. And there's always exceptions to that rule as well. So all that stuff I'm talking about, I'm just speaking like in general terms. When you look at your bell curve, we're focusing more on like the norm, right? The stereotypical norms, multitasking versus compartmentalized. Okay. And these, in light of relationship stuff, these are actually good things because it makes two different pieces to the puzzle fit, right? It's your classic, relationship strategies where one person's strength is another person's weakness and vice versa, and therefore it fits, right? So those two people come together and they form a team, and uh, through that teamwork, the goal is to always try to meet each other somewhere in the middle. Okay. The extremes on one end or the other are typically not good. For example, if one person is a big spender, okay, they just like to, so for every dollar they make, they spend $5. Well, that's not good. And the other person is a big saver, so they save too much. Well, that can be not good. And in healthy communications, you can work each other to the middle and come up with a budget. Okay. If both parties are on one end of the spectrum, so let's say both parties are big spenders, then they're going to need a third party to come in to help move them to the middle. Okay. Um, so that's very common in the relationship world, where you have strengths and weaknesses, and in areas where it is the same, which means you are on one extreme or the other, then you'll likely need a third party to help move you to the middle. Okay. So, but overall, kind of the laws of attraction and just kind of the laws of relationship stuff, you typically have difference of opinions on just about every topic. All right. Now, on a tangent here, um, down the road, that starts to create problems. Okay. When, because people will say, well, we're just two different people. And if you think about that statement, you're like, didn't you know that like the day you met? Like you're two different people. But what they mean by that is, you have those initial honeymoon phase laws of attraction. It's like, whoa, it's just the most amazing thing ever. And then as time goes by, like let's say 5 years go by, then you're kind of like, what did I just do? Okay. And that's normal, right? Because what happens is, and this is another topic for another time, um, those initial laws of attraction are the forces that drew the two people together, and there was forces underlying that you didn't see yet. Okay, and an example is those difference of opinions, and actually it's those differences that brought the two people together. Okay, and that's all subconscious. That gets into the relationship studies as they study the brain and behavior and all these different interactions. It's really fascinating, actually, to learn that stuff. But the quick version is if people can understand the biological differences, the brain neurological wiring differences, and the hormonal differences, it should make understanding the other person a little bit better. Okay. So, like compartmentalization versus multitasking. Um, and also the difference in intimacy with testosterone talking versus estrogen, progesterone, oxytocin talking. All right. They're both good things, but they're different. And as time goes by, the goal is to always try to work each other toward a healthy middle. Now, by the way, that's called the power struggle, where you're trying to work each other toward the middle. And usually um, in relationships, that people don't know that they're doing the power struggle, because it's not something we are really taught in our culture. We're not really taught how to have healthy relationships. You're just kind of thrown out there, and you let the laws of attraction take over, and passion and honeymoon effect and that kind of thing, which that's a good thing. But at some point, it's going to get deeper, and the deeper you go into the relationship, the more complicated it actually does become. And so, not understanding certain neurological wiring and differences just makes it even harder. Okay, so the power struggle that was developed by a PhD psychologist named Harvald Hendricks, and he talks about what happens when two people fight, and these are unhealthy forms of fighting. So that's why he calls it the power struggle. to try to work each other toward the middle. Like here's an easy example. Just a really easy example. Well, let's go out for dinner. Okay. Well, I would like sushi. I want a hamburger. Oh, great. Now we've got two different opinions on where you should go for dinner. And what ends up happening through the power struggle, it turns into a big fight, and then there's no dinner. And then two people go to the opposite corners of the house and they don't talk for like 2 days because they're pissed off at each other over a very simple topic of where are we going to dinner. Two different opinions, power struggle, meaning you're trying to one up each other through the argument, and then it ends in disaster. Okay. So there's a way to have those conversations without getting to the point where everyone gets upset. And so it takes a long time to learn how to manage the power struggle to work each other toward the middle. Okay. It just takes time. And you'll get there quicker if you have coaching. And if you don't have coaching, then it just takes longer to get there, if at all. So that's called the power struggle. And the reason for that is because of neurological wiring, difference of opinions, and then how we communicate with each other based on the way the brain is wired. Okay. And then you have the association fibers, which are okay, right here. It's where the wires meet each other. Okay, and that connects the areas of the cerebral cortex with the same areas in the hemisphere. Okay, it connects the areas. All right, give me one sec. Okay, so right here, the association fibers connects areas of the cerebral cortex.
Your screen's not
You're
sharing.
not sharing.
Okay, so I drew these two things because that's the association fiber. So it's connects the area of the cerebral cortex within the same hemisphere. Within the same hemisphere. Okay. This one has to do with cerebrospinal fluid circulation. We did that in lecture. This one is another thing we did in lecture. This is just showing you where the sympathetic division is, T1 to L2, and then where the parasympathetic division is, which is craniosacral, so out of the brain stem and sacral region. Okay, this one talks about how the sympathetic division, the reason why you know you're in sympathetics is because of epinephrine, norepinephrine. And the parasympathetic is because of acetylcholine. Okay, this one is showing the same thing as the slide before. T1 to L2 is your sympathetic division. And then craniosacral is your parasympathetic division. Okay. The cervical plexus is C1 to C5 is the cervical plexus. So these are the nerves that come out of your neck and innervate different areas in your, your neck, throat area. Okay, this is the brachial plexus, and we're going to be spending a bit more time on this one. Actually, I'm going to rotate this. All right. Okay. All right. So the brachial plexus gets a little fancy here. So let's dive in. Okay. So this is a C5 to T1. Okay. So C5 to T1. So there's C6, C7, C8, and T1. So these are the different nerve roots that come out of the lower part of the neck and innervate a lot of things in your upper extremity. Okay. All right. So the part that comes out of your spinal cord, that's the nerve root. And they give it a name, C5, C6, C7, C8, and T1. As you move away from the spinal cord, okay, so you're traveling more distal, it's going to change names, okay? And here's those names. So C5 turns into the axillary nerve. And we'll be doing this again. So like right here, you'll be seeing it again, okay? So C5, axillary nerve. All right, so let's take a look at it. Okay, here's the axillary nerve right there. When you trace this back, it goes to, it starts at the C5 nerve root. Okay, now when we talk about these things, we're going to talk about sensory and motor. Okay. Sensory, the way we test for it is going to be, actually, let me do it this way. Okay, so sensory tests are going to be Q-tip and pinwheel. And motor is going to be muscle testing and at times your reflexes. Okay, and at times means not every single nerve root we can do a reflex because you have to use a reflex hammer. Okay. All right, so the Q-tip is pretty much what you think. You're using something that is soft. Okay, so when you test the person with a Q-tip or something that's soft, like like a brush, for example, so the neurological tools that you have can vary. So Q-tip is fine. Some places have a very specific, almost looks like one of those paint brushes that you would do like watercolor with, right? So it's your stylus, and at the end is the brush. But the point is it's soft. Okay. So just for simplicity reasons, we're going to say Q-tip and pinwheel. All right. The pinwheel it has a handle, and at the end of it, it has a wheel, and the wheels have spikes on it. Okay. And these spikes are designed to elicit pain and temperature. And you roll that wheel across the area of interest. Okay. All right. So the Q-tip is designed to elicit tactile. Okay. The motor, you can do muscle testing, and that would be the area of interest. If we're looking at C5 nerve root, axillary peripheral nerve, then you're going to test the deltoid. Okay, so these are area-specific nerves that go to area-specific places in your body. Okay, you don't just go up to the quad and test it and go, oh, C5 nerve root. No, because the quad is a very specific nerve root and peripheral nerve. Okay, also make sure you know the difference between nerve root and peripheral nerve. So the nerve root is here, C5, C6, C7, C8, T1. As you move away from the cord, it turns into a peripheral nerve, axillary nerve, radial nerve, musculocutaneous nerve, median nerve, ulnar nerve. Okay, and we're going to be looking at these in the arm, or the upper extremity and the lower extremity. All right, so we're starting with the axillary nerve. Now, I wanted to get some of this housekeeping stuff out of the way because these tests are going to continue with each nerve root and each peripheral nerve that goes with the nerve root. All right, so you're going to hear me say kind of over and over again, Q-tip, pinwheel, muscle test, and those areas where we can, then reflex hammer. These are neurological tests because what you're trying to do is you're trying to figure out if this person has a peripheral nerve lesion or a nerve root lesion. Okay, peripheral nerve lesion. Now, your full chain of events is it peripheral nerve injury? Is it nerve root injury? Is it spinal cord itself injury? Is it a brainstem injury, a thalamus injury, or a cortex injury? Because that's your entire neurological pathway. So if you think about it, if you look at your hand, the information goes from your hand all the way up to the brain. And there's a lot of pathways involved. Okay. So now we're not going to get that advanced with this stuff. We're going to do a little bit. Okay. But just to let you know, it can get really fancy. And then you can get into your images. You can look for different hotspots in the brain. This will help you with stroke victims, with spinal cord victim injury people, with peripheral nerve issues, with whatever. And this is stuff I deal with all the time. Neuromusculoskeletal injuries. We're trying to figure out what's going on. Patient comes in. I can't move my shoulder. Okay, what's going on? Is the muscle itself hurt? Is the nerve, the peripheral nerve hurt? Is the joint hurt? Is it because the AC joint in the shoulder is not functioning, shutting down the area? Is it the spinal cord? Is it the brainstem, the thalamus, or is it the brain? We have a lot of figuring out to do, okay? So it can get quite fancy and quite detailed, but for our purposes, we're gonna stick with just a few basic things. All right, Q-tip, pinwheel, muscle testing, and reflexes, okay? All right, give me 1 second, okay? All right. Let me get rid of some more of this stuff here. Okay, we're gonna go till like 12:25 or so, so just hang in there. All right. Okay, so axillary nerve is C5 nerve root. For muscle innervation, it's deltoid. So that's motor. For sensory, it's that area of the arm. How do you test for sensory? Q-tip. Pinwheel with the spikes. Okay, now what you do with the Q-tip is you're going to test everything bilateral. All right, so the Q-tip, you take it and you touch the person with the Q-tip over that sensory area, and you say, does this feel the same as this? So you stroke them with the Q-tip in that area on the right side and in the same area on the left side, and you simply go, does this feel the same as this? Then you do it. Okay, that was the Q-tip. Then you do it with the pinwheel. Okay, the one with the spikes. Does this feel the same as this? And you take the pinwheel and you touch both areas, that specific area on both sides. Why that specific area? Because that's you're testing C5 axillary nerve, sensory. Because remember, they came in. My shoulder right here feels funny. Okay. And now you're going to do different tests to figure out what the heck is going on. All right. So Q-tip elicits tactile. The pinwheel, pain, and temperature fibers. All right. So check this out. Remember this? Cross section of the spinal cord. There's the gray matter. Okay. Divide the cord in half. All right. This is the person's right arm, right axillary area, right deltoid. Now, you don't know this. What I'm about to draw, you don't know this. So here's the right side of the cord. Here's the left side. But this is the lesion. So I'm going to put an X. That's the lesion in the spinal cord. You also know that this area of the spinal cord is the dorsal columns. So it's responsible for tactile. So actually, let's go back. No, let's just stick with it. That's fine. Okay, so you know that the dorsal columns, the fasciculus gracilis and the fasciculus cuneatus, are responsible for tactile information. They're part of the dorsal columns located on the posterior aspect of the spinal cord. Now, you just tested it with the Q-tip. So what happens is the information went in, but it couldn't go anywhere because there's a lesion on the right side. But you also tested the left side, and so information came in and went up and over to the brain just fine because the left side is spared. So the patient says, I could not feel the Q-tip on my right shoulder area, but I could feel it on the left. And you go, well, that's interesting. I wonder if it's because it's the dorsal column, specifically the fasciculus cuneatus, because this is upper extremity, right? Belly button up. I wonder if there's a lesion there on the spinal cord. That's why they can't feel it when I use the Q-tip, which elicits tactile. Now watch this. Change colors. All right. So you're going to do pain and temperature, which is the Q-tip, the pinwheel. So you okay. So what, it's not erasing, so that's just great. All right. So what you did is you took the pinwheel and you put it over the deltoid area and you said, does this feel the same as this? Now what happens is, because it's the right side, okay, and you just tested them, the information came in and went over to the spinal thalamic tract and went up to the brain. Now that area is spared because the track is spared. So they felt it on both sides. Yes, I felt the pinwheel, but no, I did not feel the Q-tip on my right one. So that goes back to our spinal cord map. And now you're like, well, I think the area around C5 in your neck, dorsal columns, is not happy, specifically on the right side because they could not feel it on the right. Okay. Now over here with muscle testing, because it's deltoid, you simply have, the deltoid helps with shoulder abduction, right? You abduct or take the arm away from the midline because of the deltoid. So first of all, just see if they can do it. Can you lift your arm like this and you kind of mimic it for them? See if they can do it. The other way is you have the person put their arm in that position and you're going to push down on it and you say resist. That tests the deltoid. So that's muscle testing. And if it's weak, now the question you have as the examiner, is it muscle? Is it joint? Is it peripheral nerve? Is it nerve root, brainstem, thalamus, or the brain itself? Okay. All right. So in this case, they, let's just say they could not do it. The muscle went weak, and it blew out. All right. So obviously they have something going on, both motor and sensory, at the C5 nerve root or axillary peripheral nerve. Something's going on. So now we know what areas to image. You're not going to image the whole body. We're going to image the neck. Well, why the neck? Well, because that's where C5 is. So I need an MRI or a CT of the cervical spine, and we are going to focus, once we get the results, we're going to focus on the C5 area. And let's say it comes back, oh, look at that. Look at that injury to the spinal cord itself causing all these problems. Okay. All right. Let's go to radial nerve. All right. The radial nerve okay, this is a posterior view of the person's arm. All right, posterior view. And so the muscles, so motor, are all the extensors of the arm. So tricep extension, which is extension at the elbow. Extensor carpi radialis. Extensor carpi radialis are longus and brevis. Okay, the extensor pollicus, the extensor digitorum, extensor digiti minimi, extensor. So radial nerve, quick version, are the extensors of your arm. And so for muscle testing, you just go after the tricep. Okay. So you're going to have the person put their arm in a position so that you can push to have them flex their tricep to see if it's weak or not. Okay. This is the sensory area. Okay, so the shaded part you see there, that would be the sensory area. And remember, sensory, you're going to do Q-tip and pinwheel. Does this feel the same as this? Always do it bilateral. All right, so this would be C7 nerve root. So radial nerve is C7 nerve root. And this one also has a special test of the reflex. Okay, so you can take your reflex hammer and you can strike the tricep tendon, okay, which is right there at the elbow, kind of almost where your funny bone is in the elbow. So you're going to strike the tricep tendon and you're going to look for the elbow. You know, it's the knee jerk reaction, but it's in the elbow. So the arm would jerk. So it's the elbow jerk reaction instead of the knee jerk reaction. All right, so we happen to be able to throw in an additional test here, the reflex hammer, striking the tricep tendon, which means you're striking, you're testing for radial nerve, C7 nerve root. Okay, this is the musculocutaneous nerve. All right, it goes to the bicep. All right, so this is C6 nerve root. So C6 nerve root or musculocutaneous peripheral nerve. Okay, so muscle testing is the bicep. So you're going to put their arm in a position to force them to flex their bicep to test the bicep muscle. So you're going to push and they're going to resist you through the bicep. And you're looking for muscle strength versus weakness. Okay, this is the sensory area. So that's where you would run your Q-tip and pinwheel. Okay, does this feel the same as this? You do it on both sides. That is sensory. And bicep also happens to have a reflex. Hammer. Okay, so you strike the bicep tendon and you're looking for the bicep elbow jerk reaction. Okay, they would flex at the elbow. Now that one happens to be, if you look here, there is a little bit of overlap with the nerves, especially when you trace it back to the cord. So if you have a positive finding for reflex hammer, which means it was diminished, then that you would be thinking C5, C6. Okay, so some of these nerves do overlap. Now the good news is, even if it's multiple levels like C5, C6, fine. When you do an MRI or a CT, they actually image the entire neck. So, you know, let's say you're like, I don't know if it's C5 or C6, could be either one. There's a little bit of overlap. Once you get the image, it doesn't really matter because they image the whole neck. They're going to get everything. All right, ulnar nerve. Okay, by the way, that spot right there is your funny bone. I'm not sure why they call it that. If you hit that area just right, you send a zinger down to your pinky and ring finger area because you just hit the ulnar nerve. Okay, so that's your so-called funny bone. And it's actually not very funny when you hit it. All right. Okay, so this is the sensory area. So pinky, so digit 5 and 4. And the lateral, well, let me say that better. The hypothenar area. Okay, so the thumb area is the thenar. Opposite it is the hypothenar area. All right, so it innervates the hypothenar area, which is everything you're seeing here, including digit 4 and 5. Okay, that's sensory. Okay, this is C8, nerve root. There is some overlap, so it's C8, T1. Okay, so the sensory area is your Q-tip and pinwheel. And as far as the muscles, it's your flexors. Flexor carpi, ulnaris, flexor digitorum profundus. Okay, then in the hand, it's the adductor pollicis. Okay, so it's the thumb's ability to add to the midline. Okay, the way that we would test this one is you take your thumb, add it to your pinky. Okay, actually you can do that right now. Just take your thumb and your pinky and touch them together. That's called, that's a certain action. And then you just try to pull it apart. Okay, so that's one way you can muscle test that. Try to pull those apart. Okay, median nerve. You can see the median nerve there. By the way, this nerve, if it is hurt, causes carpal tunnel.
So what are we supposed to feel on the pinky and the
Well, hold on. I'm so sorry. You were breaking up that entire conversation. So what'd you say?
You said we should put our big toe, big finger and the toe and pinky together. What are we supposed to feel?
Well, no, I'm just saying that's the muscle test. So you can just have your patient touch their thumb and pinky together
Mm.
just to see if they can do it.
Okay.
And then if they
Oh,
can,
okay.
if they can do it, just try to pull it apart. Say, you know, touch your thumb and pinky together, hold it there. I'm going to try to pull it apart. Don't let me.
Oh, okay. I got it. Thank you. Thank
All
you.
right. Yeah, you're welcome. And if that area is hurt or not working, then they're going to be very weak or they won't be able to do it or they're going to fail the muscle test. And if you do your pinwheel and Q-tip on that sensory area, then they won't feel it. I mean, if they fail the test. And if they fail the Q-tip, that's dorsal column. If they fail the pain and temperature, that's the on your spinal cord. Remember that when it comes in, pain and temperature crosses over and goes up. So that means that area was hurt. Okay, median nerve, if it is infringed upon, can cause carpal tunnel. Okay, as you can see there, there's a carpal tunnel flexor retinaculum that the median nerve has to pass through in order to get to those three fingers. Okay, digit 1, digit 2, digit 3. All right, so that's the sensory area is the thumb, the first finger, the middle finger, better said, digit 1, digit 2, digit 3, and then the thenar area, which is like the fat pad of the thumb. Okay, median nerve is C6, nerve root. So if this area is hurt, is it C6 nerve root or is it the median nerve? And if so, where is the entrapment? All right, so your sensory test is the Q-tip and pinwheel. And this is the area of the hand that you would do it. And in fact, you run it over each finger. So the thumb, or digit 1, digit 2, digit 3, Q-tip, and then do it on both sides. So does this feel the same as this? So you do the thumb, right and left, and then the digit 2, right and left, digit 3, right and left. And then you're going to do your pinwheel. So always test bilateral. And if you use your Q-tip, that's tactile. If you use the pinwheel, that's pain and temperature. Reason why is because of the level of the cord, right? So if the dorsal columns are hurt, that's tactile. If the anterolateral system is hurt, that's pain and temperature. Because your pain and temperature comes in, crosses over at the level of the spine and goes up. Your tactile comes in and goes up dorsal columns and then crosses over in the pyramids. Okay, lumbar spine. The lumbar plexus, L1 through L5. And then the sacral plexus is S1 through S5. Okay. The lumbar plexus, the main nerves is the femoral nerve, obturator nerve, sciatic nerve. Well, that's in the sacrum, lumbar and sacrum. Okay. Tibial nerve. All right. So the obturator nerve There's obturator nerve. Okay, this is gonna, for muscles, this is gonna go to your adductor muscles. Okay, so the muscles, kind of the groin areas, people usually say in kind of lay terms, I just pulled my groin. So it's those inner thigh muscles. All right, this is the sensory area. So that's where you would do your Q-tip and pinwheel. And then this would be your muscle test. Okay, and what you're gonna do is you're going to push their leg that way. Okay, you're going to push their leg laterally. In order for them to resist, they have to fire the adductor muscles. So that's the muscle test. Just have them fire the adductors by pushing their leg away from the midline. Okay, L4 nerve root. Okay, and with sensory, Q-tip, pinwheel, does this feel the same as this? You test both sides to see if they can feel tactile, and then pain and temperature. Okay, femoral nerve. All right, there's femoral nerve. Okay, it's L3, L4 nerve root. All right, and it comes down and basically innervates the quads. Vastus lateralis, rectus femoris, vastus intermedialis, vastus medialis, right? So this is quads. So that's the muscle test, is your quads. All right, so quads does extension at the knee. So your patient is sitting there and you're going to push against their leg. And what they're trying to do is actually push the other way. That's extension at the knee, which tests the quad. So that's the muscle test. Sensory is a pretty big area. So basically, you just run the Q-tip over the quad area and then your pinwheel over that quad area. Does this feel the same as this? Okay, also this one has special test reflex. The patella tendon. So you're going to take the reflex hammer, strike the patellar tendon, see if you get the knee-jerk reaction, because that is a quadricep function, to see if they can do it or not. Okay, and you're testing that level of the cord, L4 area. All right, tibial nerve. Okay, the tibial nerve runs down pretty much the back of your leg, the posterior aspect of your leg. Okay, so there's an expression, L5 heel jive, S1 reach for the sun. Okay, L5 heel jive, S1 reach for the sun. What that means is to test the L5 muscle, which is your the anterior tibialis muscle, because that's what lifts the foot up. Muscle testing, you do L5 heel jive. So have them walk on their heels, which means they have to lift their toes up and lift their foot up. So that is dorsiflexion. S1, reach for the sun, means you go on your tippy toes because you're trying to reach for the sun. And that is a gastrocnemius function, right? So that big muscle on the back of your calf there, if you flex it, it points your foot, points your toes, right? So that's how you get on your tippy toes. So for muscle testing, that's one way you could do it. You could just have them, yeah, and you usually mimic this for the person. So you do it and then have them repeat after you. So you walk on your heels. Can you do this and walk on your heels? And can you do this? Walk on your tippy toes. Now, it's also pretty obvious if it's not a good idea to have them stand up and do this, and then you just use your hand. You just grab their foot and you push on their foot to make them resist you with their calf muscle or gastrocnemius, and then you move the foot the other way to have them do the tibialis anterior. So it's safer. Okay. All right, so tibial nerve, muscle testing, S1, reach for the sun. Okay, so the muscle you test is the gastrocnemius. All right, this is the sensory area, which is basically the calf area. So that's your Q-tip and pinwheel. Does this feel the same as this? If they complain of the pinky toe going numb, it is likely tibial nerve. I get that a lot. I mean, not personally, but like my patients come in and that's their complaint. At mile 3, my pinky toe goes numb. Okay, probably tibial nerve. So we look at those areas. All right, fibular nerve, sensory is this area over the fibula, should give it away, fibular nerve over that lateral part of the lower leg, which is where your fibula bone is. Okay, the muscle testing, go after the anterior tibialis muscle. So that is your L5 nerve root, fibular nerve. Remember L5, heel, jive. So have them lift their foot up, walk on their heels, see if they can do it. If that's not safe, then you grab their foot and muscle test it by saying resist. Okay, they're trying to lift their foot up while you're trying to push down. Oh, back over here on tibial nerve, because it's the Achilles tendon, we can do a reflex hammer. Okay, so Achilles tendon. And you're looking for the foot to jerk. It'll do plantar flexion. Okay, and that's testing for S1 nerve root. Okay. If a person gets a herniation, now that you know that map, you can likely tell where the area of the herniation is. So like if they come in complaining of this area, okay, it's probably an L3, L4 herniation. All right, so the herniation happens in the spine, so the nerve root will be affected. femoral nerve, for all intensive purposes, is spared because the nerve itself is fine. But the reason why femoral nerve is pissed is because L3, L4 is pissed, and that's what actually creates the femoral nerve. So in other words, a person can get hurt in the leg, an actual trauma to the leg, not the spine, and femoral nerve is shut down. The spine is spared, the L3, L4 nerve root is spared, but because the femoral nerve was hurt in the periphery, that's why they're having the symptoms. So this is why we do the test, and this is why we do images, because then you can verify. So it is definitely possible. What if they had a stroke and that part of the brain affected that part of the leg? Okay. So the femoral nerve was not hurt. The nerve root was not hurt. The spinal cord was not hurt, but the brain was hurt that operates that stuff. So that's why it shut down. Okay. So what we just did with Q-tip, pinwheel, muscle testing reflexes is something that you can do right then and there with your patients, and it reveals valuable information on what might be going on. All right. Now, for what I do, I would say 97% of the time, the people that come in, I can treat them right then and there. So we do these tests, we figure it out, and I can treat them. Probably about 3% of the time, it's creepy, it's dangerous, and it's a surgical consultation, and then I refer them out for surgery. All right. So in other words, people can have these problems, but it's not always a surgical case. You can fix it through conservative management, physical therapy stuff. But granted, there are some people where it's so bad, and the damage is so significant that you can do all the physical therapy you want. It's not going to help them. They need the surgery. And if I pick up on that, then, I talk to them. I was like, man, this, every test we did is not only positive, but very positive. You're very symptomatic. The trauma, your history, none of that is good. So I don't want to do any treatments today. Let's figure this out and get an MRI right away. So we do. And then the radiology report comes back and it is just nasty stuff going on. So then I call the patient. I'm like, look, here's the radiology report. Here's what they said. You need to make an ortho neuro appointment. If you don't have anyone, here's the people I recommend. If you have someone, then go to them. But this is a surgical case. Get a second opinion from a surgeon. See what they have to say, because this is creepy. This is a red flag. I do get those. Okay. But the majority of people that come in, it's we can fix it, work on them right then and there. But sometimes we do have to refer out. After they're done with the surgery, they're going to need some post-op rehab. Okay. Now, the really, really advanced stuff, they just go straight to the hospital. Your stroke victims, your spinal cord victims, brain trauma people, they just go straight to the hospital. They're not going to go into a PT clinic. But this chronic, nagging, reoccurring pain, I'm so over this. My wrist, all this typing, all this mouse work, this is stupid. And then they go into someone like me. Those people usually don't go to the hospital because it's not bad enough. Okay. All right. Any questions on any of this? Okay. All right. Well, let's take a break. Let's reconvene probably around 1:35. Okay. And at that point, I'll just we're pretty much done. All right, with everything, but around 1:35 or so, we can reconvene on Zoom, and I'll take any questions. I'll certainly post a bunch of review things for everyone because, you know, we have tests next week, or finals, I should say. And I'll get all that posted for you. Not over lunch, but, you know, by the end of the day, you'll have everything you need for next week. All right, so I'll see y'all at